welcome everyone. Thanks for joining us today. The video, you basically saw it. It just didn't have the music playing in the background, and we can get the link out to you. It's just a nice little short video that the Washington puts out for advertising women veterans. So just take the opportunity to introduce myself. My name is Julie McNeil. I am a licensed clinical social worker with the Department of Veteran Affairs, and I work for the Veterans Health Administration part of the Department of VA, and I am at what's called a Veterans Integrated Services Network office, Business 17, and I am the lead Women Veterans Program Manager. And I'll go ahead and let Joanne Hurricane introduce herself.
Hello, I also am very grateful that y'all invited us to speak to you. I am an attorney with the Department of Veterans Affairs. I represent the agency, and I think my piece of this presentation is to talk to you about some information law issues.
Okay, so this is a overview of what we'll be discussing today, and we will certainly allow time for questions any way that we can help you all in how you're serving the women veterans. Next slide, please. So this is an overview of the Department of Veteran Affairs. Some people that may not be familiar with it, this helps kind of map it out a bit. So as you'll see in the middle, the three rectangles under the Department of Veteran Affairs, under the VA Secretary, you have the Veteran Benefits Administration, which handles benefits, claims veterans might have for injuries in the service, education, loans, etc. Veterans Health Administration, which is who I work for, the healthcare side of the house, and then the National Cemetery Administration. The Center for Women Veterans reports directly under the Secretary, and they help advocate and do outreach to these three groups and in the field. And then down below at the very bottom of the screen, you'll see Women's Health Services in green there is at the Washington level. And then what's not, well, you'll see the VISN office, which is in the blue, the Veteran Integrated Services Network, falls under the Secretary, and then but we really work closely with the Washington Women's Health Services office and the healthcare systems. Next slide, please. So I'm assuming most people that are dialed in are in Texas, but if not, this is another picture just to show the VA and how we're currently broken up into VISNs, which are networks. We're consolidated, regionalized health systems led by a VISN director, and then we work closely with each of the healthcare systems that report under us. So we're in VISN 17 in Texas, and you'll see we cross over a little bit into New Mexico as we have some clinics there. Currently, the Houston VA does not report under us. There's some discussion of reorganization with their move under us at some point, maybe later in the year. Next slide, please. And this is a breakdown of all the VA healthcare systems in Texas. And then you'll notice that the two bottom bullets, we do have two Texas clinics that fall under different VAs. It's just how that was mapped out at one point prior to some reorganization we had a few years ago. And that will come into play a little bit later, but this will help kind of a broader overview for you all, and that link at the top is a directory for your future reference. Next slide. Okay, so discussing women veterans. So the numbers nationally as of September 30th, we had over 19 million veterans, and then of that number, over 1 million were women veterans. And by 2020, it's expected that women veterans will make up 10.5% of the total veteran population. So currently in Texas, we have the largest population of women veterans, and as of the last data that came out for end of fiscal year 16 was over 177,000. And you can see the second in line is Florida, and we have 30,000 more women veterans than Florida, and the other states fall below us. For our Visit 17 area, projected growth from fiscal year 16 forward, you can see that continued growth is expected in our area. Next slide. This is a breakdown too by our VA healthcare systems of the numbers that are enrolled. The uniques, what that means is a unique person that is a more frequent user, where someone might be enrolled one year but maybe they don't come to the VA. The uniques are the ones that are coming through our system. And then the last column, the women veteran population, is a breakdown by each healthcare system's catchment area on the number of women veterans in the area. And you can see, unfortunately, there's a large portion that aren't currently using the VA. All the more reason why we need to continue to prepare to meet their needs, not only in the VA, but in the community. Next slide, please. Okay, so your women's health team at your local at your local healthcare systems consists of your women veteran program manager. So there is one at each healthcare system, and the clinics that report under the main site, they also work with those facilities as well. So they're a leader in the organization to ensure that women's health needs are met and directives are followed. They lead strategic planning for the system, see what gaps there might be, needs, advocate for women veterans. They do outreach. They work closely with the other department managers in the system to ensure that women veterans' needs are met. Then each site also has a women's health medical director. This is a clinical leader for women's health, so they are seeing patients on a regular basis, but they also lead the team in maybe education and updates for women's health needs at the healthcare system. And then the VISN lead for women's health is myself. We have 18 VISNs across the nation, so there are 18 VISN lead women veteran program managers. And so my role is to work closely with the facility level women veteran program managers in meeting needs and doing strategic planning, working with other leadership and service chiefs in the facility, again, to ensure we're meeting needs of our women. Next slide, please. This is a listing, a handy list I would keep for further reference, a breakdown of each of the program managers at each of our sites. Next slide, please. Okay, so the services VA provides for enrolled women. Of course, some are similar to men, and then there's some unique needs of women, of course. So we provide comprehensive primary care to women. And let me just back up a bit for some that may not know. For eligible veterans that are inquiring about receiving VA care, they could contact their local women program manager if they have not enrolled with the VA or to learn more about their benefits, and they would walk them through the process to sign up for care. So we provide services to eligible veterans. We do not provide care to the active duty. They would get their care through the Department of Defense, through the military base they're assigned. Now, as a part of the veterans' care, we would see the spouse or the children, for example. If someone needed family therapy, then that may involve the spouse or couples therapy and possibly the child, but we do not treat the child or the spouse separately if they are not a veteran. There are some facilities that may have support groups, caregiver support groups for one example, but our primary mission is to care for the veteran. So in that, most of the first stop is in primary care, where you have your regular physicals done. to address any chronic illness, acute care illnesses, any gender-specific needs, and the goal is to have one provider to do that for, say, the annual breast exam, pelvic exam, etc. The VA offers routine gynecological care or through primary care, but they also have the option to see a gynecologist for specialty care gynecology needs that are above and beyond what might be met in primary care. And then, of course, a wide range of mental health care, both inpatient and outpatient, residential treatment, substance abuse, etc. Disease management, prevention, and screening is offered. We have mammography at many of our sites. For some of our smaller sites, we make referrals into the community to ensure the women are getting the preventative care that they need. Our larger sites have emergency rooms, and care is available through there. And I will get into some of these others in more detail about infertility and maternity care. But a wide range of services is offered, as you can see, through the VA. Next slide, please. So one of the things that we emphasize in the VA is our women's health primary care providers. Every provider, whether they work for the VA or not, usually have a background in family medicine or internal medicine and have training on how to care for women. But what VA has done is we offer additional training and refreshers on how to care for women and the women veteran and their unique needs. And nationally, the VA has trained over 3,700 providers. And in the VISN, we have for the last, we're going on 3 years now, do a refresher training for our providers that is a reminder to them of unique needs and give them up-to-date information. And we also have a training for our primary care nurses. And some studies have shown that the veteran is more satisfied when they are assigned to a women's health primary care provider. And we do offer trainings for other staff within the VA as well. Next slide, please. So this is just a picture of the group of some of the training we've done. This one was in Temple. Actually, this was the first year, and this was outside of their women's clinic. Next slide, please. And then this is training we're doing for nurses, and we've actually got one coming up next week in San Antonio. Next slide, please. So some folks don't know that we offer maternity care services for our women veterans who are eligible to receive VA care. And so each of our sites does have a person designated to handle maternity care coordination. So if you have a veteran who is pregnant or thinking of becoming pregnant, I would ensure that they are linked up again with the women's program manager, who in turn can link them up for services in the community where VA would pay for their care up to 7 days for the newborn after delivery. Some resources on the right there, the Text for Baby and Mom Mood Booster are apps that they can use and are a helpful way to get them through their pregnancy and after birth. Next slide, please. So I won't get into this slide in detail, but it's more for reference for you later, is the VA does do infertility evaluation and treatment for female and male veterans to those that are enrolled. Something new that has occurred in the past year or so is that a part of that is in vitro fertilization may be provided when clinically appropriate to a veteran who has a service-connected disability that results in the inability of the veteran to procreate without the use of fertility treatment. So again, if you have someone that might be eligible or need more information, the local women veteran program manager is the person to reach out to. And what's new as a part of that ruling is adoption reimbursement. So the VA amended its regulation to provide reimbursement of qualifying adoption expenses incurred by veterans with a service-connected disability that results in infertility. So again, the local facility person is the best person to reach out to for that. Next slide, please. Okay, so as mentioned earlier, VA has mental health care, both outpatient, inpatient, individual, and group therapy, residential care, so programs specifically related to substance use disorders, post-traumatic stress, maybe military sexual trauma, where some groups may be all female or male, some co-ed groups, evidence-based therapy to help the veteran work through whatever issue they may be going through. We use peer support and counseling. We also refer out in the community to the military peer support network. And then if you have someone that may need mental health care that is not engaged, then again, for any veteran, you may start with your local social work service department, mental health, or for a woman veteran, you can contact the Women Veterans Program Manager for more information of what's available at the site nearest them. Okay, next slide, please. So a big topic that I'm sure you all have heard about is the women veterans and military sexual trauma. However, it is unfortunately not just women, it is men, although we do see men who have suffered military sexual trauma as well. So it is a sexual assault and repeated threatening sexual harassment that occurred during military service that may or may not have happened by the perpetrator being in the military as well, but that's where most people think of that is by another service member. So we know approximately 1 in 4 women report having experienced MST versus 1 in 100 men. And some of that is probably underreported in both genders. VA does provide free care for MST-related health conditions, and veterans seeking treatment has increased, as you can see, over since fiscal year 16, 62% versus 49% for men. So eligibility for care is expansive. There's no documentation of MST required. The service connection is not required. However, it may benefit the woman to speak with a benefits counselor to seek that out if they desire. There's no length of service time required, and some veterans can receive the MST-related care even if not eligible for other types of VA health care. Next slide, please. So every VA has a MST coordinator as well. Now this is a collateral duty, so it's usually someone that has also a caseload of patients they see in therapy and individual and group, but they are a point person for MST issues at the facility. They do work closely with the women's program manager and may also serve on various committees with them. They're responsible for addressing system issues that may be a barrier to accessing MST-related care. For example, sometimes we have turnover in frontline staff who may not know that we do have a special eligibility for folks that are claiming MST issues where they may not otherwise be eligible for other VA care. So ensuring that they are educated and trained to know that service is offered. We also engage in outreach related to MST, different awareness months, and the Clothesline Project, for example, is one project where sites take advantage of those interested veterans who want to participate in telling their story of their trauma and how they do that. Okay, next slide, please. So post-traumatic stress disorder. So the VA has a National Center for PTSD. The website's there. There's a wealth of information for you all on there for veterans or families as well as professionals. And there is a page on intimate partner violence on the PTSD page as well. Again, this is to help re-educate, educate, and train not only those in the VA, but also in the community for those working with veterans. There's also a directory of treatment programs available across the nation for PTSD, but don't hesitate to contact either myself or your local points of contact we are mentioning in this training to get access to that information. Next slide, please. So complex trauma, as you all are working with folks who are probably coming into your centers, you're probably seeing a lot of this. So not only may they have suffered or are suffering from some type of intimate partner sexual assault, maybe they have had a history of childhood abuse of some sort. They may also have had some military sexual trauma, trauma from combat, etc. So those layers of things can make things difficult for the person. And if you'll show the next slide, please. Just some characteristics of complex trauma. Again, things I'm sure you're seeing in the folks that you are seeing through your centers. Persistent sadness, explosive anger, suicidal thoughts, maybe difficulty trusting others or maintaining or establishing healthy relationships, feeling detached from their one's body, dissociating, and some feelings of shame, guilt, feeling different or damaged. Next slide, please. So suicide prevention is been in the VA for quite some time, and I'm sure you've heard a lot about it. The Veterans Crisis Line is a national line that can be used for someone in crisis. There's been some more attention drawn to women veterans, as we've seen rates increased in recent years with women. And among the women, the highest suicide rates are those younger than 40 years of age. Some risk factors, which are not necessarily just women specific, but history of mental illness such as post-traumatic stress, depression, drug and alcohol misuse, and some history of military sexual trauma, as well as intimate partner violence. And there's been some correlation that we have seen with MST, other types of intimate partner violence and substance abuse as putting women at higher risk for killing themselves. Next slide, please. So here are some other resource information that we're sharing. The crisis line, if you don't have that, there's an online chat available for the Veterans Crisis Line and resources there. And then there's at least one, and at most of our larger sites, 3 or more suicide prevention staff that work closely to track those at high risk for suicide, help coordinate care, and work with the treatment team for that veteran. Each facility also has a women's health, mental health champion. So some of the training I'd mentioned before for many residencies, there was some national training on women's specific mental health issues. So there's a point person there at each site that works closely with the other team members. So intimate partner violence overview in the VA. What the VA is doing. So you can see on the slide, according to the National Coalition Against Domestic Violence, in the general population, 1 in 3 women and 1 in 4 men have experienced some intimate partner violence. However, in the VA, through the Center for PTSD, states that for the veterans, the number could be twice as high. And women who use the Veterans Health Administration, the lifetime intimate partner violence experience is 30% to 70%. And you can see the difference in the reporting there. So when a woman veteran comes in, again, mostly they're coming in through primary care. There are some that might choose to just see mental health care in the VA, but they're reporting in probably those 2 places primarily. The VA is working on some things nationally to fine-tune education and screening of these veterans to ensure care coordination, offer services they may not be receiving to help them through their experience. All right, next slide, please. So the VA takes a veteran-centric approach and looking at the different factors that a person may be involved, whether it's post-traumatic stress, military family stress, etc. And then we know that these things can lead to increased risk of broken families, loss of support, homelessness, joblessness, poverty, and even suicide or homicide. Again, there's some statistics up there for you to see. And unfortunately, there's the relationship between domestic violence or intimate partner violence and concern for our veteran population with increase in the divorce, homelessness, joblessness, etc. And specifically with women, as I'm sure you all know, if they have children involved, then trying to find them housing as they are leaving the abuser may be difficult to accommodate themselves and their children, especially if they have male children. So that is something we look to the community to help us with in supporting these women. Next slide, please. Just some other information about the service members and veterans is the past year prevalence rates of those using intimate partner violence among male veterans, and then women veterans experience intimate partner violence at rates higher than their civilian counterparts. And high rates of PTSD and interpersonal aggression suggest that women are at a higher risk for intimate partner violence. Next slide, please. So the VA nationwide has different priorities. Suicide prevention is definitely one of them. So again, since the suicide and intimate partner violence are linked, the importance for screening to get that information from the person to best help them is things we are starting to roll out. Probably more so in the next month or so. We should hear more about that from the national office. And if you've worked with folks within the suicide prevention realm, you'll know that not everybody's going to come to you to say, hey, I'm suicidal, can you help me? A lot of times you have to look at the different signs and symptoms and ask them questions around that to get some feedback and let them know it's okay to report, it's safe for them to report, and we're here to help them. So 85% of individuals who experience IPV are women. It's the most common cause of non-fatal injury and multiple health consequences and increased healthcare utilization. And again, it's not only affecting their mental health, but the physical health in their whole world. So again, our goal is to best help them and to work with folks like you to help meet their needs. And then as far as geriatric care, IPV accounts for over 30% of substantiated reports of elder abuse, and 2 out of 3 are women. All right, next slide, please. So again, some things VA does to raise awareness. These are VA Pulse or SharePoint resources are in-house tools that we use for staff, public and staff-facing websites, work groups. There is a memorandum of agreement with the National Domestic Violence Hotline for those folks to ask if they're veterans and then to link them up to someone in the VA for services that the veteran desires. Again, additional training that's available within and outside VA. Next slide, please. All right, so I'm going to turn these next few slides over to Joanne for discussion on release of information and privacy.
Thank you, Julie. As I said when we opened, I'm an in-house lawyer for the VA. I represent the agency. I don't generally represent individual veterans, although occasionally it turns out that the interests are the same. I think that many veterans are concerned about receiving health care when they realize that someone's writing everything down and somewhere down the road what they said could become released outside of their medical record. And that's kind of what I want to talk about because I think it's an important consideration. This is focused on Texas. Let me tell you a little bit about myself. I prior to VA, I didn't have healthcare experience. My career experience was about 2 decades of courtroom work. So I have a lot of litigation experience, but it's pretty Texas centered. So my information law is all through VA, all my experience, and it's all through Texas facilities. So if there are people on the call who are outside of Texas, it may be that in your state, it is mandatory for a provider, for example, an emergency room doctor, to report intimate partner violence. In Texas, it is not mandated. And what that means in VA world is we are prohibited from reporting anything without a veteran's consent. However, sometimes intimate partner violence can occur in a situation where mandated reporting to authorities is triggered. If there's a child involved, if the person who is victimized is over 65, or if the person who is victimized is in some way vulnerable, then it could be that VA is mandated to report it to authorities. But in the typical sense, the typical scenario, it wouldn't be. VA would not be reporting to authorities. There's some examples. In some states, it's mandated that gunshot wounds be reported to authorities. In Texas, it is not. So that is not something that would normally be reported. Some states, it's mandated that a healthcare provider report a rape, a violation of a criminal law as a result of violence. That's not true in Texas. So it is more likely that VA is not authorized without the patient consent to report that to any authorities. They would be advised of what they, of the community support and resources that they could access, but it would not be a VA instigated or initiated report. And so mandated reporting of domestic violence, intimate partner violence is not applicable to the state of Texas, but is applicable in some other states. Next slide, please. What I worry about, and I have actually seen these scenarios, one of my jobs is whenever VA in my region gets a subpoena from a court for records, it crosses my desk, and I have to apply federal privacy laws to determine whether or not VA is going to turn records over. And I know that some people, some women veterans, may choose not to seek health care, particularly mental health care, that they desperately need because they are concerned about disclosure. So that's something that you may come across in your practice, some reluctance to get medical care because of that fear. So what I can tell you, next slide, is that I believe that records are more secure in the VA healthcare system than they are in the private sector. So whereas private sector healthcare, they have essentially one law, HIPAA, that governs release of personal health information. We have a slew of laws that we have to apply to every request. Yes, we have HIPAA, but we also have the Privacy Act. We have this special law that includes special protections for alcohol and substance abuse treatment information. And we also have a set of regulations that severely limit when we will send a witness to testify. So sometimes that cuts against a veteran, but more often than not, I'll get for example, a DA subpoena who's involved in a child, a CPS case where they're representing CPS, and they're seeking to terminate mom's parental rights, mom being a veteran, and they want the VA mental health care provider to come and appear in court and bring the records. That's highly unlikely to happen because of the regulations and laws that provide greater protections in VA world to healthcare records than in the private sector world to healthcare records. So for whatever comfort that might give to somebody you're counseling, I can tell you that I take the responsibility for protecting healthcare information extremely seriously. And I can't tell you it's never going to be disclosed, but it's going to be much less often than in the private healthcare sector. I think I have another slide, maybe not. Can you check? No, we're bound down to resources. Julie, you want to talk about this? And then I think we're going to open for questions, right?
Yes. Thanks, Joanne. So, yeah, as a tag onto what Joanne was saying, what I didn't mention earlier is there is implementation of an intimate partner violence coordinator at the VA to ensure that each site has at least one. The sites that have them now, it's a collateral duty similar to the MST coordinator, but again, nationally the VA is looking to roll out some more guidance and information for that role, as well as what we can continually do and improve upon in the VA healthcare system. And so they can be a consultant to providers, for example, on what's appropriate to document in the chart. And for safety planning, for example, is to not give verbatim details of a person's safety plan if they need to exit their situation with their abuser. And the My Healthy Vet is an online chart that veterans can sign up and get access to get their records and also communicate with their provider through that computerized system. So, being careful to give their password out, or maybe they need to change it frequently, etc. But some things to keep in mind as you're working with them, because the goal is if they're not seeking treatment, we certainly want them to, and not for that to be a barrier to seek treatment is concern about their safety and privacy. So some additional resources here. Nationwide, the VA has a Women Veterans Call Center, and the number's there. They also have a chat function. And again, this is not a crisis line like the Veterans Crisis Line. If someone were to call this number in crisis, they would certainly assess the crisis, and then if it needed to be warm transferred to the National Veterans Crisis Line, they would do so, and easily can do that. But that's a resource for you as well. With the caller calling into that center, they are also offered a referral to their local Women Veteran Program Manager. All right, next slide, please. Some other resources, websites continue the main women's health page for the VA, and there's a section of that focuses on women's health and intimate partner violence. VA Monthly has educational campaign materials that they put out for women veteran use that both can be used in-house and outside the VA, different posters and such that can be printed off some of these sites. The Center for Women Veterans is, again, that group that reports directly to the VA secretary. There's a wealth of information and access to other things within the VA on their website, directories, the benefit side of the house, the VBA, again, the crisis line. has a wealth of information on that website. It lets you track down where the nearest VA is, suicide prevention team, a Veterans Readjustment Counseling Center, etc. And then the Make the Connection site is a really nice site for anyone to use, but for veterans, they are veterans telling their own story of how they worked through their trauma, their recovery, little short videos, both a combination of men and women, combat, non-combat vets, some with MST scenarios, etc. So it's a very good site to go to. So the veteran can maybe identify with someone on that site and hopefully seek help if they have not. All right, next slide. And here are some points of contact within social work service. Me being a social worker, I guess I'm a little partial, but I worked in the VA for actually 25 years. March was my anniversary. I've worked at a local healthcare system up until I started working for the VISN about 4 years ago. And I work closely with the social work chiefs at this level as various needs come up. And so this is a way to reach out to find a social worker, which if they are not the right person to help you, they are very good at finding where you need to go in the VA system. So help navigate the system, which can be cumbersome at times. All right, next slide. I think we're almost. Okay, so that's the contact information. So we'll just go ahead and open it up to any questions or comments people have. Maybe there's case scenarios you want to bring up, whatever we can do to help answer your question.
Thanks. I'm sorry I jumped on top of you, but there is a question regarding data in the context of being able to use the data to affect legislative changes. And I guess, Joanne, that's for you.
Well, I don't know. Julie is probably closer to policy policy movements than I am, and also with what data we have. I know that we are highly, there's so much oversight of our programs that we have a tremendous amount of data, and how it's being used to affect particular legislative initiatives, maybe Julie could speak to.
And I'm sorry, can you repeat the question, Wendy, how the data is used?
Right. In the context of being able to use the data to affect legislative changes.
Okay. For,
maybe it would be help to know, is the person who's asking the question interested in federal legislative changes or state legislative changes? Maybe more specific about which legislation initiatives they're thinking of.
Okay. Can I unmute you? Anna, I'm going to try to unmute you so you can ask your question. I'm happy to try. Hold on. I can't find you. Let me see. You should be here somewhere. Okay, Anna, you're unmuted. Go ahead. Okay.
Can you hear me?
I can hear you.
Wonderful, wonderful. So, so my question is, when Joanne was talking about the IPV and some of the mandates around reporting or disclosing incidents, and she kept saying, but not in Texas, but not in Texas.
Okay.
So,
let me explain why not in Texas. And that probably doesn't answer your question, but it'll give it a little more context. VA has regulations and laws that say we are allowed to disclose information to state agencies like DFPS only when there is a specific state law that says you must report. So if the state of Texas has a law that says you must report IPV, then VA would report IPV. And there's only a few things that Texas requires providers to report that I'm aware of, and I look at this frequently. It's going to be the elder abuse, the child abuse, and then there's some health things that have to be reported.
Okay, so I have an opportunity to actually put forth legislative recommendations. So my question would be, if the data could be determined, if we could get the data to show that because we don't report it in Texas, that there's I guess I'm not even sure how to say it, but some kind of data that would support us being able to push for a change in our legislation that would say it has to be reported now. But something that shows, when it's reported, it's acted on and there's less incidents or there's more education or whatever the case may be, having that data allows us to put forth justification for why in Texas we should be doing the same. Do you see where I'm going?
Yeah, and Julia, do you want to comment?
No, it's a tough one.
I'm sorry. I was going to say, I'm not sure we even have that kind of data.
Yeah.
And typically, VA would not take a position of what a state law would say, or should say.
Right. So I'm not necessarily looking at it like that, and maybe we can take this offline because I don't want to cut into some of the other questions. But I appreciate the response, and I know there's a lot of data protection, and I absolutely understand all of that. So maybe it just requires further discussion, maybe outside of this forum.
Great.
And Anna, I'm happy to follow up with you and see, if you're looking more for the prevalence of the issue and seeing how that can help. But yeah, I'll be more than happy to speak with you.
All right. Thanks, Julie. Thanks, Joanne. I appreciate it.
Sure. And the other thing I wanted to add here is that TAASA has a public policy committee. And if you would like to get in touch with Chris Kaiser, CKAISER at TAASA.org, he might be interested in knowing what it is you are looking for and how it might be coordinated here in Texas. Does that make sense?
Yes, ma'am. Thank you.
Okay, so or contact me and I will be happy to forward the information. Okay, I've got some questions about, will you get the PowerPoint? Yes, it's coming in a follow-up email that you will get in your inbox, hopefully. If not, please check your junk mail because sometimes it goes there. And the PowerPoint will be in there, a link to the certificate of attendance, as well as the evaluation. We would really, 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 really appreciate it if you fill out the evaluation and return it to us so that we can look at whatever we need to look at. At the same time, I would also appreciate on those evaluations if there are topics that you want for further knowledge, discussion, whatever, to put them in there, because that will also help inform what kind of webinars TAASA puts on in the future. So that's my little plug. Thanks. Okay, any other questions, comments, suggestions? Because I can unmute you. I've got that power. That I can see coming in. Okay. I want to thank both Julie and Joanne for taking the time today, because their schedules are so busy. They were just so busy in order to coordinate just talking and getting this down. So I really, really appreciate it. I thank you all very much. Julie or Joanne, is there anything you want to say in parting that you may want to talk about?
What I would like to say, Julie, sorry, is that when you encounter female veterans, please encourage them to explore the availability of VA healthcare. They do a good job taking care of veterans who have often very specific issues that private sector healthcare may not have a range of experience in.
And
thanks, Joanne. And yes, I'd like to just reiterate that. You know, certainly if anything we didn't cover today that you have questions about, please reach out to me. You have my contact information there. You know, I didn't get into detail of every little thing for time's sake, but also wanted to give time for questions. But we are there for you all to help support the veterans' needs, and also to help the veterans access the care they deserve and benefits. And so if they don't access us, then they don't sometimes know what services that they are entitled. And as far as related to intimate partner violence, I think with suicide prevention, as it has become more and more prevalent in the VA, which as I worked in that role prior to this one for 7-8 years, it's really it's about education and awareness to those in the community, those that may suffer with issues, and so that they know we are there to help them, both in and outside the VA. But we have caring folks that are willing to help and also be of resource to you all as you help the women that you come into contact with. So please don't hesitate to reach out to us. Even if it's an issue where you're having trouble with the VA or navigating the VA or whatever it might be, we are very open to that information to correct any issues and to help the veteran.
And I want to add something else, that we're talking about medical issues here, but I also know that there are programs out there through the VA and through the Texas VA system that will help women in particular, but veterans in general, to get on with their lives in terms of business plans and GEDs. Am I correct in that assumption? Because I was floored when I found that out.
Yes, I will say I've lived in Texas before and been in Oklahoma and I come back. And the Texas Veterans Commission, which I know Anna and Pam are on the line, we work closely with them. They do a wealth of things to help support veterans in the state, which I think we do quite a great job of that in Texas. Compared to other states, it seems like that, and that's what I hear from my colleagues outside of Texas is, wow, you all seem to do a lot for veterans. So there's a lot of resources out there, Texas Veterans Commission being one of them, and to ensure the veterans, again, have access to all the potential availability of services, whether they're trying to go back to school, get out on their own, maybe after they're leaving an abuser, or getting a divorce, or whatever it might be, to help better themselves and their future lives.
Well, I want to thank you all so very, very much. Pam told me I went mute, and I'm sorry, that's not Wendy, but I'm joking. I hope you all can hear me. I am delighted that this went on. Again, any questions for anyone please do not hesitate to contact any one of us. And if you have lost the information, do not hesitate to email me and I will get you the information that you need. Okay, anything else from anyone? Okay, with that, I'm going to take down I'm going to close out the webinar. Thank you so much, everybody, for your time and attention today. And we'll see you in cyberspace next week. Bye-bye.
Thank you.
Thank you.